Welcome to this delightful evening. I extend a warm welcome to all participants joining us for this enlightening scientific webinar. This webinar is collaboration with the Institution of Reproductive Medicine and Women's Health, the Madras Medical Mission with Madras Mission, and the academic partner Universal Nutrисcience. It is a truly pleasure to witness the gathering of India's top-notch IVF expert on this platform. Once again, I welcome to all. We at UNS, we pride ourselves as one of the fastest growing nutraceutical company by offering what best class nutraceutical products. Our infertility portfolio, which includes the brands such as CoQ300, which is for RPL and PR patients. CoQman is for especially for the male infertility. CoQ Family in PCOS, CoQLC in male infertility. And we are having CoQ Photo, which is both for the couples, male and as well as female. This product which helps the patients to empower their parenthood dream. And with this, I would like to invite our medical expert manager, Dr. Vikas Singh. He is going to introduce our faculty members and he is going to set the context for this today's proceedings. Over to you, Dr. Vikas. Dr. Vikas, can you hear us? Hello.
Hello. Hello, Nakul.
Yeah, please.
Madam, Vikash laptop, there is some issue. He's rejoined once again. So meantime, I request Nakul, you have the CV, no? You can introduce both the chairperson.
Just
Dr. Ramesh Raja as well as Ajanta Bhubali, madam.
No, Mr. Balaji, I don't have CVs. Just I will request Dr. Vikas.
I will send it, Saka. 2 seconds.
Yeah, please. Yes, doctor, he is sharing CV. Dr. Vikas, can you hear us? Dr. Vikas.
Maybe I think I can introduce both Dr. Ajanta and Dr. Ramesh.
Yeah.
I think Ajanta is a consultant from Nova IVF Center, a well-known ART specialist who's done her RCOGA from UK. And we have Dr. Ramesh Raja, a well-known embryologist and is an executive member of TAPSR to start the sessions. I request
I can introduce myself. I am Dr. Mona Pandurangi, Associate Professor from Ramchandra Medical College, and I've been associated with IRM and take part in some of these academic feasts. And thank you, Dr. Kundavi, for calling me for this program today.
An excellent examiner too.
No. So can I share my slides, ma'am?
Yeah, please.
Can you see my slides, ma'am?
Yeah.
Yeah. So my topic today is coenzyme Q10 and oocyte aging, the effect on ovarian reserve and oocyte. My slides are not moving. Yeah. 1 second. Just a minute, madam.
Yeah, please.
This is coming up. Okay. So can you see my slides, right?
Yeah.
Ovarian aging. Okay, ma'am. So ovarian aging is a biological clock. Life expectancy of human being has greatly increased from 45 to 85 years over years, but the age at natural menopause has remained around the age of 50 years. So ovarian aging is a part of normal biological aging where genetic as well as environmental factors influence its onset and determine the age of menopause. We are very much aware of this graph which we study from our time. So we know that by around 16 to 20 weeks, around 10 million oocytes, though they migrate, by around 16 to 20 weeks, they start decreasing gradually. And by the time of birth, there are only 1 million oocytes left in the ovary, and by menarche it is 3 lakhs, and then and so on. It gradually decreases with a rapid decrease around 32 years to 37 years, and then it progresses to ultimately with no oocytes by menopause. Okay. Now, can we have control over this ovarian aging? Now, career oriented women are choosing to delay childbearing to more advanced age by resorting to ART and planned oocyte freezing. So, they are freezing the oocytes into this test tube, and they can plan their pregnancy whenever they say, now I have done with my career and am ready to carry a baby. So, SDA recommends planned oocyte freezing ideally before 35 years of age. The chance of achieving pregnancy with each mature oocyte thought from the preserved oocyte is only approximately 6.55%, which further decreases with age. So, just by freezing oocytes, a very few number of people or who wanted to achieve pregnancy were only 6.5%. That means the oocyte quality of oocyte is also compromised with reproductive aging. Now, what is the evidence that the quality is decreasing? Now, this is one of the evidence that the genetic integrity of oocyte is decreased with advancing age, and almost half of the women are infertile by the age of 40. And in one of the study, they have found that by the age of 30, there are 34% of the embryos are aneuploid embryos. By 35, 42, it goes on increasing. By the age of 42, there are 81% of aneuploid embryos. As a result of this, we see that there is a decrease in the live birth rate, and an increase in the aneuploidy rate and increased miscarriage rate as maternal age advances. And this is very well shown, wherein they studied the aneuploidy taken from a donor embryo and compared from the fresh embryo transfer as per age. And you can see that in case of donor embryo, who are usually young girls chosen, the aneuploidy rate remains the same, whereas those where it is where the advanced age, the aneuploidy rate increases. Now, what are the controlling factors of oocyte quality? Can we control this factor too? So, poor oocyte quality is not restricted to aging process alone. Many other intrinsic and external factors, including environmental pollutants, may lead to an altered microenvironment surrounding the oocyte. And oocyte requires huge amount of energy, that is ATP, to ensure proper maturation and embryonic development. Where does it come from? Mitochondria, which are in abundant in the oocyte, produce the required ATP. So any mitochondrial dysfunction can lead to an inadequate supply of ATP, which can affect oocyte maturation, fertilization, and embryo development. Thus, to maintain oocyte competency, optimal mitochondrial function and adequate ATP levels are required. So, what happens actually whenever there is mitochondrial dysfunction? Whenever there is reduced mitochondrial function, okay, it leads to lower ATP availability and lower antioxidant capacity, resulting in higher ROS production, increased oxidative stress, and this again causes mitochondrial damage, and thus the vicious cycle goes on. Now, there should be an oxidative balance in the body. A reactive oxygen species are normal byproduct of a mitochondrial function that can progressively damage the constituents of mitochondria, including the mitochondrial dysfunction, if antioxidant fail to tackle. So in the process, whenever there is a mitochondrial function, there are ROS produced, but you should have an antioxidant of sufficient mechanism, an efficient mechanism to counter this. Hence, a balance of pro-oxidant and antioxidant is required to maintain a state of oxidative balance and prevent mitochondrial dysfunction. So, what happens whenever there is reduced mitochondrial function? It results in lower energy ATP availability and lower antioxidant capacity. So, whenever there is lowered ATP availability, there is decreased energy availability, which compromise the oocyte maturation, fertilization, pre-implantation embryogenesis, leading to arrested cell division and abnormal fragmentation of the embryo. Lower antioxidant capacity results in decline, increased oxidation of mitochondrial DNA, causes mitochondrial dysfunction that can affect fertilization, developmental competency of the oocyte. So, with the aged oocyte, the alterations in the mitochondrion that are seen are mitochondrial DNA copy numbers are altered, mitochondrial mutation load is altered, membrane potential, there is an alteration, there is a defective electron transport. All these changes are thought to be either contributory to or a hallmark of oocyte aging. Now, this is one of the very old study which was done by Jacob Bento and Robert Kasper. This was an animal study. What did they do? They pre-treated for 52 weeks a 52-week-old mice with mitochondrial nutrients like coenzyme Q10, alpha-lipoic acid, resveratrol before ovarian stimulation and flushing of the oocyte from the fallopian tube and studying them for their various maturity aspects. And this data demonstrated that CoQ10 treatment, but not with other two nutrients, was associated with increased oocyte number and oocyte mitochondrial activity parameters similar to the oocyte from the young ICR control. That means, though they were old, there was a reversal in the quality of the oocyte, and it was seen more with QCAN10. And thus they thought that supplementing the diet of older women with mitochondrial nutrients like CoQ10 can result in an improvement of oocyte and embryo quality and subsequently a better pregnancy outcome. Then they started the study in human, and in 2014 they came out with this paper. The same group came out with this paper wherein IVF ICSI patients between 35 to 43 years of age, 39 patients were treated with either 600 milligram of CoQ10 or an equivalent number of placebo. Long protocol CAH was done and the oocytes were analyzed for post-meiotic aneuploidy rate using polar body biopsy and CGH. What did they find? The rate of aneuploidy was 46.5% in CoQ group compared to 62.8% in the control group. So there was a difference. Clinical pregnancy rate was also, there was a difference, 33% in the CoQ group, whereas 26.7% in the control group. And what they found that the CoQ10 rescues the spindle defect in the aging oocyte, and that's how they improve the oocyte quality. Now, what exactly is this CoQ10? It's a fat-soluble, lipophilic molecule ubiquitously situated in the hydrophobic domain of all the cell membranes. CoQ10 is mainly self-sensitized in the human body, utilizing collection of enzymes located in the mitochondrial matrix membrane, while a small portion comes from exogenous supplementation. So it's mainly synthesized in the human body. It helps mitochondria in the synthesis of ATP. Any deficiency of regulatory factors, raw material, and enzymes in the synthesis process may affect energy production and oxidative phosphorylation in the mitochondria, aggravating oxidative stress. So, what are the antioxidant functions of CoQ10? So, reactive oxygen species are normal byproduct of any aerobic respiration which in the mitochondria and play an important role in maintaining cell growth, metabolism, and other physiological phenomena. Most free radicals are ROS, including superoxide ions, hydrogen peroxide, and hydroxyl radicals. However, when the amount of ROS exceeds the scavenging capacity of the endogenous antioxidant system, the balance of the redox system is disrupted and ROS accumulates in the body and oxidative stress occurs. So, theoretically, antioxidant function of CoQ10 may reduce the RSO release. Now, an altered ovarian environment with high oxidative stress causes mitochondrial dysfunction, which may not be directly related to insufficient CoQ10 levels. So, it may be just aging where the CoQ10 levels are normal. In those cases, it is said that raising the CoQ10 levels may benefit oocyte quality by the means of mitochondrial function enhancement and thus improves these patients' symptoms. So, how does supplementation of CoQ10 help in reproduction? Increasing CoQ10 levels may reduce oxidative stress and enhance mitochondrial function. Preclinical studies in animals have suggested that CoQ10 can protect ovarian reserve, possibly counteracting the physiological ovarian aging by restoring mitochondrial function and augmenting embryo cleavage and blastocyst generation. CoQ10 supplementation may thus constitute a potential therapeutic option to overcome suboptimal oocyte quality as regard the crucial role of mitochondria in achieving optimal oocyte maturity. Further, CoQ10 supplementation has been shown to have epigenetic effects on genes involved with signaling, intermediary metabolism, transport, disease mutation, and phosphorylation, and in embryonal development, indicating a role in gene expression. Now, when should we supplement? When should we supplement? In vivo, that is before the ovarian stimulation. Okay, it would improve the, if you supplement, then it would found that it can improve the ovarian reserve, the ovarian response and oocyte quality, increases the number of cumulus cells surrounding the oocytes and their mitochondrial activity. So this should be benefit if it is given prior to stimulation. Now, supposing we have done already an retrieval of immature oocytes and IVM, can you supplement this in the culturing? Yes, added CoQ10 in vitro culture media while culturing the immature oocytes may be beneficial as the first meiotic division is not yet completed. But exposing the oocytes in the metaphase 2 to CoQ10 could be too late to counteract age-related oxidative stress-related damage. So either so best is to supplement them before obtaining the oocytes. Then there are few studies which are available in the literature. Pre-treatment with coenzyme Q10 improves the ovarian response and embryo quality in low prognosis young women with decreased ovarian reserve. It is a randomized controlled trial done in 2018. The participants were randomized to receive CoQ10 pre-treatment 200 mg TDS for 60 days preceding IVF no treatment. So what did they see? They found that the total dose of gonadotropin was significantly less. Peak E2 concentration was significantly more. Then the retrieved oocyte were more. Mean number of retrieved oocyte was significantly more. Fertilized oocyte were also significantly more, and high quality and fertilization rate was also better. The drawback of this study was they did not their outcome was only quality of oocyte and not the live birth rate. So they concluded that pre-treatment with CoQ10 improves the ovarian response to stimulation and embryological parameters in young women with poor ovarian reserve in IVF-ICSI cycles. Further work is required to determine whether there is an effect on clinical treatment endpoints. Now, this is another interesting study where can CoQ10 supplementation protect the ovarian reserve against oxidative damage? So, what did they do in this study? It's an animal study. A total of 150 milligram per kg per day of CoQ10 was given orally for 14 days via a nasogastric tube along with a lethal dose of cisplatin. Serum AH and AFCs were compared with the group given cisplatin alone or not given at all. What did they find? Cisplatin group had the lowest antral follicle and highest atretic follicular count. Atretic follicular count was significantly lower in the cisplatin plus CoQ10 group compared to cisplatin. AFCs were significantly higher in the cisplatin plus CoQ10 group compared to cisplatin group. Thus, they concluded that CoQ10 supplementation may protect ovarian reserve by improving the mitochondrial function, counteracting both mitochondrial ovarian aging and physiological programmed ovarian aging. If this is true, then our fertility preserving patients who are receiving chemotherapy, supplementation of this might be beneficial. Now, this is another study. They estimated the CoQ10 in the follicular fluid and compared the maturity of the oocyte in them. And what did they find? That the total CoQ10 levels were higher in the follicular fluids associated with mature oocyte and high grade embryos, suggesting a possible correlation to the mechanism of control and growth in follicular ambient. This is a random systemic review and a randomized control trial. 5 randomized control trials fulfilled eligibility. So there were 449 totally infertile patients, 286 of whom were in the poor ovarian response group and 163 in the polycystic ovarian group. Women with poor ovarian response group received CoQ10 dosage varying from 600 mg once a day for 8 weeks to 600 mg twice a day for 12 weeks or 300. So there were different dosages which were used by different groups. And in women with PCOS, the dosage was very small, that is only 60 mg 3 times a day. What did they find? Oral supplementation of CoQ10 resulted in an increase in clinical pregnancy rate when compared with placebo or no treatment group. This effect remains significant when women with POR and PCOS were analyzed separately. No difference between group was observed regarding live birth rate and miscarriage rate. Only in one study, in the women with POR, CoQ10 increased the median number of oocyte retrieved and fertilized when compared to no treatment group. So they concluded that the infertile women undergoing ART that CoQ10 supplementation increases clinical pregnancy rate both in total and in infertile subgroup, poor ovarian reserve and PCOS group compared with placebo or no treatment. So this is another systematic review and meta-analysis where they studied all the antioxidants which were given to any advanced age women to prevent ovarian aging. This was done, it was accepted for publication in July 24. And what were the drugs which were given? Coenzyme Q10, melatonin, myoinositol, vitamins, vitamin E, resveratrol, and combination of N-acetylcysteine and acetyl N-carnitine, alpha lipoic acid. And the treatment duration of these varied from single time to 3 months of duration. You see here, the CoQ10 dosage ranged from 30 mg per day to 1200 mg per day. Total of 20 randomized clinical trials were taken with 26,177 participants were included. Women were all advanced age over 35 years with decreased ovarian reserve. What were their observations? The use of antioxidant not only significantly increased the number of retrieved oocyte and high quality embryo rate, but also reduced the dose of gonadotropin, contributing to higher clinical pregnancy rate. According to the subgroup analysis, with regard to different doses and setting, better effects were pronounced with lower doses. Coenzyme Q10 tended to be more effective than melatonin, myoinositol, and vitamins when compared to placebo or no treatment. CoQ10 showed more advantages while small improvements were observed in other drugs. In addition, based on subgroup analysis, CoQ10, the optimal treatment regime for CoQ10 for improving pregnancy rate was 330 mg per day for 3 months before controlled ovarian stimulation cycle. And so I actually asked whether this is available as 30 mg, but then the lowest dose available here is CoQ10 100 mg, which is available. This is a China study. So I don't know whether they are supplying this in 30 mg. So this is another study which had examined the use antioxidant and fertility in women with ovarian aging, a systemic analysis, and they concluded that antioxidant is an effective and a safe complementary strategy for women with ovarian aging. Among all, the treatment with CoQ10 is a promising choice for rescuing the decline in fertility. Optimal treatment regime for CoQ10 was 30 mg for 3 months before controlled ovarian stimulation, and women with DOR clearly benefited from treatment especially those of young reproductive age. So, to conclude, ovarian aging process include impairment in the mitochondrial function, a reduction in antioxidant activity, and an increase in oxidative stress, marked by an increase in reactive oxygen species production. CoQ10 is essential for mitochondrial activity and is a potent antioxidant. Decline in CoQ10 level with age due to certain drugs such as statins or due to mutations of genes involving CoQ10 synthesis leads to CoQ10 deficiency resulting in mitochondrial dysfunction and ovarian aging. CoQ10 supplementation may be a wonder drug in reversing ovarian aging. Thank you for the patient.
Thank you, ma'am, for the wonderful presentation. You gave us valuable insights on the CoQ10. And we have many antioxidants available in the market, and we really do not know which one is best for the patient and how much dose to give and how long to give and whether it's really beneficial for the patient. Thank you so much, ma'am, to give us an update on that. And I think we need to take the questions after the next session, ma'am. Thank you so much, ma'am.
Thank you.
मेरा सीएमई चल रहा है, मैं लैपटॉप से कनेक्ट करता हूँ. कुछ लाया वाली.
எல்லாருக்கும் வணக்கம். It's my pleasure to introduce next speaker, Dr. V. Geeta. She's a senior consultant obstetrician, gynecologist, and fertility specialist. She is from Madras Medical Mission Hospital. She is a member of all the associated societies. She has a special, she has Best Poster Award in World Congress in Dilemma and OBG in Nagpur. She won a third prize for endometriosis and ERT outcome endometrioma. She presented many papers in national and international conference. Over to you, ma'am.
Thank you, sir. Thank you for your kind introduction. Can I share my slide? Can you see my slide?
Yeah, we can see.
Okay. So today I'll be talking about CoQ10 in male infertility. Madam has made my job easier by speaking on female infertility and also about the pathophysiology in detail. So, sir, I think someone's mic is on. Okay, thank you. So we all deal with female infertility mostly in our OPDs, but we do have male infertilities also. And certain time we just treat them when we know the cause. And there are many times we don't know the cause and how to deal with that. So today the topic is, will antioxidant help in those type of population in general? Because today our audience mainly would be general gynec who will deal with those type of patients mainly. Because when patients come to ART specialist, they already will have a period of, trying naturally, and then maybe after a few years, they come for their IUI or IVF. So let's see how this antioxidants will help them. So what is male infertility? Male's inability to result in pregnancy in a fertile female. So this reported as alteration in sperm concentration and or motility and or sperm morphology. It accounts for about 40 to 50% of infertility and affects approximately 7% of all men. So it occurs either due to problem in the sperm or any problem with the sperm quality. So as we all know, the semen parameters, when it comes below the normal values of WHO, we consider and mark them as male infertility. And the most significant parameters where we usually look into is if the concentration is low, oligozoospermia, or if there is poor motility, actinozoospermia, and when there is problem with the morphology, teratozoospermia. So as I said previously, we almost counter about 40 to 50% of the infertility population which are having problem with male. And nearly 50% of the infertility is related to reproductive anomalies or disorders in the male. Over 25% of infertility cases, there is no detectable cause and can be traced even after routine tests, which leaves the case as unexplained infertility. So this cohort of patients also have to be given importance. And evidence now suggests that reactive oxygen species mediated damage to sperm is a significant contributing pathology in about 30 to 80% of cases. So we have to concentrate this cohort of patients, and we may not even give importance sometimes when we deal with other causes. And I mean, the problem is only with the sperm quality. So when we look into the literature from earlier period till date, so it is seen that from 1973 to about 2018, the sperm count has been fallen by 50%. And 50% of childless couples are having male infertility and the associated factors. So what is it mainly? Is it only the sperm health, or there is somewhere erectile dysfunction or problem with the libido, which the population is not, coming out with a problem? And as I said, the cohort we need to, give importance is unexplained infertility also, where we don't have any answer. So this is like a common investigation for ovulation, tubal patency, and semanalysis are all normal. And for those couple, they fail to conceive even after 1 year of regular unprotected sexual intercourse, and they are labeled as unexplained infertility. Coming to the pathophysiology. So this is the main thing which we need to know. So there are normal levels of reactive oxygen species which are required for sperm physiology. It is not that ROS is not present in the body. It is present and it is required for certain physiological functions which is happening in the body, especially sperm. And when the levels exceed, then the problem starts. So that might affect the sperm quality in different parameters, starting with the concentration, then motility, morphology, and everywhere. And as I said, it contributes to about 30 to 80%. So where does these ROS increases? In general, starting with the lifestyle factors like smoking, and when the person is obese, when he's exposed to any drugs, and even with pollution, radiation, and when he is having other comorbid factors like diabetes, cancer, and when there is any problem like immature or abnormal spermatozoa, any infections. So all these leads to increased oxidative stress, and that causes problem with the function of the sperm, and later leading to infertility. So how does this stress and male infertility is related? Human spermatozoa can generate controlled low amount of ROS that play a significant role in inducing sperm capacitation or acrosome reaction and acquisition of sperm fertilizing ability. However, high levels of ROS endanger sperm motility, viability, and function by interacting with membrane lipids, proteins, and nuclear and mitochondrial DNA. So oxidative stress produces free radicals that attack the DNA molecule, causing breaks in the DNA strand. So what happens when this level is more? Basically, there is protein damage, lipid peroxidation, which happens in the membrane of the sperm, biomembrane damage, causing even the DNA damage. Therefore, these factors result in problem with fertility. So this is a rough picture which shows about all the antioxidant compounds and their significant effect on the functions. So this is vitamin C, vitamin E, thiamine, all play a role in sperm concentration. Lycopene helps, plays a role in lipid peroxidation and DNA damage. N-acetylcysteine deals with protamination and DNA damage. Folic acid involved with DNA damage. Acetyl L-carnitine with motility, chromatin. L-arginine for vitality, L-carnitine, CoQ10, molybdenum, all for helps in the motility, and zinc and selenium with sperm motility and morphology. And there are, we do give antioxidant in general for many patients, and we exactly don't look upon the dosage of antioxidants, because we do have different combinations of antioxidants coming, and I think most of the people, when they look into the antioxidants, they will have zinc, selenium, maybe CoQ, carnitine, and also vitamin C and vitamin E. So this is a dosage. For CoQ10, it is about 100 to 300 mg, and vitamin E, it is 400. Carnitine, it is about 1 gram. Vitamin C is also about 1 gram. N-acetylcysteine 600 milligram, zinc 25 to 400 milligram, folic acid 0.5 mg, selenium 200 milligram, and lycopene 6 to 8 milligram. So let us see one by one. So, as Madam said, this ROS is basically produced in the mitochondria with the mitochondrial respiratory chain. So that as such involves and takes part in sperm capacitation, sperm hyperactivation, acrosome reaction, and sperm oocyte fusion. What happens when there is increased oxidative stress level? So when these oxidative stress level increases, the sperm membrane as such undergo lipid peroxidation, which in turn increases the ROS production, causes more DNA fragmentation and sperm apoptosis. So that is where we see many changes. There are certain things in our body which will even counteract and balance these problem when this happens, like this superoxide dismutase, catalase, and glutathione peroxidase and all. But it will take care only to certain extent. When it happens more, maybe even this CoQ10, there are it can help to certain extent. So when the exogenous CoQ is provided, I think it helps to some extent. Let's see what literature says. So in general, where do you think of antioxidants? I would say in a general gynec practice or even as a ART clinician, usually antioxidant is provided in males when the count is very less, when we deal with oligospermia, or when the person is having varicocele, increased paternal age, patient is obese, previous IVF failures, diabetes, and any comorbid factors. These are the common indications when we prescribe antioxidants. So what about DFI? Do we deal with DFI often? Or when we think DFI is more? So it is the same indication what I told. Increased paternal age, increases DFI, smoking, alcohol, diabetes, obese, cancer patients, and previous IVF failure, varicocele, all these, it is almost similar indications. And another point is, do we need to add antioxidants for all? So let's see what literature says. As I see, these are the factors where we usually, encounter in our practice for antioxidants. So this is a systemic review of, many RCTs about CoQ, especially in male infertility. So they analyzed and they have told that the qualitative analysis of available studies has shown that supplementation with CoQ10 alone or in combination with other antioxidant molecules has a beneficial effect on semen quality, especially regarding sperm motility. So improvements in semen parameters begin after 3 to 6 months of treatment, but disappear when supplementation is discontinued. Further studies are needed to establish the optimal dosage and possibly superiority of co-administration with other molecules compared to monotherapy. So this is the recent one. And so basically CoQ is an energy promoting agent, and it is an important cellular antioxidant, and it is an effective scavenger of free radicals, and it has been shown to possess protective capabilities against oxidative stress damage to mitochondria and DNA. And it also involved in energy production of the cell, particularly in the mitochondria. This energy production affects many biochemical cellular processes in the body. And it is believed that the concentration of CoQ tend to decrease after 30 years of age in some tissues. So this decrease has been correlated to the decrease in the fertility. So as when we looked into the literature, there are almost about more than 600 clinical studies which is available with CoQ across the therapeutic area in PubMed. And it is told that it is a sperm mitochondrial energizer, powerful antioxidant, and it protects membrane from lipid peroxidation, reduces the sperm DFI, thereby improving the sperm motility, count, morphology, and fertilization rate. So this was a study where they analyzed the CoQ supplementation on antioxidant enzymes activity and oxidative stress levels in seminal plasma, where they analyzed about 60 infertile men with idiopathic oligoasthenoteratospermia, and they were randomized to receive either 200 mg of CoQ or placebo for 3 months. And after 3 months, they saw that these infertile men, CoQ in these OAT infertile men can attenuate oxidative stress in seminal plasma and improve semen parameters and antioxidant enzyme activity. So this was a study where they studied the CoQ effect on partner pregnancy rate in infertile men with idiopathic oligoasthenoteratospermia, and which dealt about 287 infertile men, and they were treated with 300 milligram of CoQ orally twice daily for about 12 months. And they saw the overall pregnancy rate was about 34.1% with a mean of about 34%, and this improved the semen quality with a beneficial effect on the pregnancy rate. And this was a study where they supplied 200 mg for 3 months, and they saw there was improvement in the semen parameters, oxidative stress markers, and it also reduced the sperm DFI in infertile men with idiopathic OAT. So this was a systemic review where they analyzed the effect of antioxidants on sperm parameters, and what they noticed was L-carnitine was ranked first in sperm motility and sperm morphology, whereas this omega-3 fatty acid was ranked first in sperm concentration, and CoQ10 had better effective treatment on motility and concentration. So this was, like empirical therapy in idiopathic male infertility, the study, and they said that all physicians who treat infertility should bear in mind that empirical therapy can improve semen parameters and subsequent fertility potential even through natural intercourse. So there are many novel phytotherapies which are available for male fertility challenges, especially. I think these combinations are seen in the market. So I thought I'll just enlighten about one slide. They call it as TTS, Tribulus terrestris, and which is also have an androgen mimetic action, which increases the production of testosterone and enhances spermatogenesis. And the other one is Alga eclonia bicyclis, which is found to be a potent antioxidant, and it is 10 to 100 times more powerful with a long-lasting half-life. And the other one is chitosan oligosaccharide, which increases the NO production. There are many combinations of these drugs seen along with CoQ or other antioxidants. The other molecule which is seen in the market along with CoQ also in combination we see is myoinositol. The main role of myoinositol in sperm health is it promotes spermatogenesis by regulating FSH, LH, and inhibin levels, and it also helps in sperm maturation through activation of protein kinase. And the level of myoinositol is seen more in gonads and epidermis, suggesting an involvement in the osmoregulation of seminal fluid. It reduces a amorphous substance in the OAT spermatozoa, especially thereby improving the sperm motility, and also improves mitochondrial function of sperm and increases the influx of calcium, and it enhances the fertilization ability. So when they studied the effect of these phytotherapies when combined with CoQ and also myoinositol, so they saw it helps in production of the good quality of sperm, regulates testosterone, FSH, LH, and inhibin levels, facilitates sperm maturation, enhances the motility, and decreases the sperm DNA fragmentation, reduces the ROS damage, supports the fertilization process, and also positive effect on erectile function, ejaculation function, and also libido. This was a study which they gave dose for the a dose studying thing. They gave doses of 200 and 400 for two groups, and when they saw, they found more improvement in men who took 400 than in 200. So there are a number of studies with the dosage as well. So coming to the other molecule one by one, the other most common molecule which is used is L-carnitine. This is a study which had 170 patients, and 1 gram of L-carnitine was provided for almost 3 months, and they saw that there was improvement in motility, and the morphology was improved with these type of, with patients with L-carnitine. And this also improved, this is in general, when they compared before and after, they saw concentration, motility, and the forms were, morphology were improved. And when they used for patients who had varicocele and supplied them with L-carnitine, this was a study, they saw that about for 53 patients who had varicocele, see, when there is severe varicocele, I think there is no role for antioxidants alone. So they those patients are scheduled for surgery. But when it comes to mild or moderate, so what do we do? So in those type of patients, this was a study with low grade L-carnitine with low grade varicocele improved the sperm parameters. And this was a multi-center study where they enrolled 100 patients, received 3 grams per day of L-carnitine for 4 months, and they saw there was a significant improvement in motility, morphology, and concentration. And this study wanted to know about the effect of varicocelectomy and oral carnitine patients with varicose. And they said based on the results, so this study said that medicinal administer semen parameters and can be used as an alternative to surgery for varicocele grade 2. And the other molecule, the other thing is ubiquinol and sperm parameters in infertile men with asthenoteratozoospermia. Here, 100 milligram ubiquinol was provided for about 6 months, and they studied that changes in morphology and motility were significant. What is ubiquinol? Ubiquinol is a reduced form of CoQ10, and ubiquinone is oxidized form of CoQ10. Ubiquinol is an antioxidant or a protective form of CoQ10, and it also neutralizes the free radicals and thereby prevent them from damaging cellular DNA, lipids, and proteins. So ubiquinol elicit higher circulating levels and absorption of CoQ10 and also increase the activity of the mitochondrial pathways that lead to energy generation required for sperm motility. Coming to the other molecule, lycopene. In this study, about 30 patients were included, and they had 2000 microgram of lycopene twice a day for 3 months. And they saw there was some improvement in the concentration, motility, and the morphology. And the sperm concentration were improved. And the other molecule is astaxanthin, which we encountered at some point. So this effect of astaxanthin was evaluated in capacitating buffer, which induces low ROS production and low percentages of acrosome reacted cells. Sperm cells were incubated in the presence or absence of increasing sperm concentration of astaxanthin, and ROS production, the tyrosine phosphorylation pattern, and percentages of ARC and non-viable cells were analyzed. What they saw was phosphorylation and without the generation curve, and it also created a membrane of phosphorylation sperm. And when they saw the results with astaxanthin, the ROS levels were significantly reduced. Pregnancy rate more with the patients who had astaxanthin, and which we see in our population, which used commonly is zinc. It plays a vital role in the metabolism of RNA and DNA, signal transduction, gene expression, and regulation of apoptosis. Zinc amino were found significantly higher in fertile men in comparison with subfertile. Zinc thought to deliver an protective effect on stress, flagellar abnormals, hypertrophy, and hyperplasia fibrous sheath, enzymal disruption, inner microtubular and also absent mid-piece all be associated with. So they compared to no, it was in a prospective trial in men with asthenozoospermia. It was given for 3 months. The results revealed a significant improvement in concentration, motility, and also reduction in anti-sperm antibodies. So coming to take home message, when we, as I said, do have a population where we include antioxidants like aged varicocele, previous IVF obese patients, diabetic, cancer patients. So we need to also look into these type of patients where we don't have a cause, especially in idiopathic oligospermia patients also, and give them a benefit of antioxidants for at least 3 to 6 months, which would be beneficial. Giving or 1 to not help. And the only for CoQ as such, most of the studies, they say 200 should be enough, but sometimes when we analyze the severity is more, we can even give the dose up till 300. And there are many studies and many form of molecules we have, like different therapies we need to have more clear RCTs on on those things. But in general, combinations can be given, and the duration of further treatment should be 3 to 6 months, I would say. Thank you.
That was a very beautiful presentation, ma'am. It was a very detailed one. And we are very benefited about each and every antioxidant, how the role plays in male infertility. Thank you very much, ma'am. And I personally like that one single slide where the sperm, you showed the sperm with the different antioxidants act on it. Thank you very much for your lucid presentation.
Thank you, sir.
Any questions? We can take it up now.
There are some questions on the chat box.
Yes.
The CoQ10, the dose recommended and how long?
In female infertility, most of us in India, what they are telling is 300 milligram twice a day. But then what I presented the study was as low as 30 milligram is enough. So that was a China study. But then when I spoke to these people, they said that it is not available as 300 milligrams. So how they gave, we are not sure. So at least minimum 2 to 3 months, as we always say, that follicular, there is a non-gonadotropin independent phase where it has to improve. So maybe at least 2 to 3 months prior to may be beneficial.
Do we need to give CoQ10 routinely, ma'am, before starting the stimulation? Do you think so? Or we can
I don't
only
think
the patients
so.
are waiting.
Only patients in whom I think maybe where they are decreased ovarian reserve patients, young age particularly, they might benefit more than, and even in elders who have a real DOR, or you have seen poor quality oocytes, next cycle you're doing, we can supplement them with this. I think that is where we are not giving it routinely at all.
Yeah, we do have patients with tubal factors where they undergo for IVF. So I think routine is not required. I mean, think that there might be problem with the oocyte or the reserve, then we can give them.
Mona, is it safe for them to continue during the IVF program, or we should stop before the?
I think it can be given, ma'am, because it is no way it has action on the mitochondrial function. So I don't think it has any, and there is no side effect even on overdosage. So that is what they said, that in patients of DOR where there is normal concentration of CoQ10 levels, supplementing this and making it a little more might boost up the function. So there are no such side effects with these. This is basically like a vitamin.
See, for example, we have had one Muslim lady, whatever we have done, we have taken her for 12 days of stimulation and things, lot of immature eggs, in spite of, doing it with Sona AVC, making sure that the follicles are 36 hours, dual trigger. In spite of it, the number of eggs, and most of them were immature. Maybe those patients probably, there's a benefit in using that.
I'm not sure, ma'am, but then what they say is that, it has to act prior to our stimulation. It should be given and it would act better. Or you give it when you're doing a in vitro maturation. But then with mature oocytes, it's not much of beneficial. So when you are getting an immature egg, probably supplementing earlier might make a change, or it may be just immature oocyte syndrome probably in that patient, wherein there is ineffective action of these HCG in that.
I think it can be beneficial in PCO patients where we think that there could be some oocyte competence issue, and we can pre-treat them along with our metformin and other things.
Yeah, but then everything comes with a cost. So just giving it empirically to all the patients might not be that. So unless you have proved, because say more than 50% of the time you get good oocytes, not that every time we get poor quality oocytes in a PCOS. So how many adjuvants are we going to add in every PCO patients? So it's really difficult to decide.
Just my little bit of experience when I did IUI cycles for PCO patients, whenever there is some sort of a resistance, or when we are going to add gonadotropins 2-3 cycles, it really did not work. So when we added this coenzyme Q,
okay,
found that the response was better. It's a very small observation, but I just wanted to kind of.
Now, we have not used it in a PCO patients, though there is a literature wherein what I presented, it has shown to be beneficial, but we have not used it unless we have got poor quality oocytes on doing retrieval. Then if they are going for a second stimulation, we have added, but initially we have not given.
Maybe all because we know PCOs tend to have this spindle cell problems there, so maybe maybe. And again, because there's one group who brings a combination of coenzyme Q10 with ubiquinone and dose combination. And there's a combination of, as Geeta brought it on, with a lot of other antioxidants. So how do we go about, suppose if a male partner has got multiple parameters, got an abnormality with morphology, motility, so we give a combination, or how do we choose the antioxidant?
I think
we give a combination or a single thing, depending on a patient's profile.
Combination would be better in those type of patients where we have more problem with that.
No, that's the combination is not the ideal dose.
There is no
coenzyme Q10. That's the combination antioxidants.
Yes, ma'am. At least 200 should.
Because ideally, if you say they talk about 300 twice daily or something, right, for a coenzyme Q10. So if you give it in a combination, the drug has got a potential effect on it.
I mean, this is
yes, because there are many.
You're talking about in male.
Male, yeah, male.
I think the male require a lower dosage. Dr. Geeta, is it so?
200. Yes, most of the studies they say 200, ma'am. 200 is
lower. In the female, they are saying here, at least in India, they are promoting, and what one or two literature says they have gone up to 1,200 milligram. So maybe 300 BD is okay for them, but in males they have used a lower dosage.
This is most of the studies they say 200, but still there are few few people they have studied for 400 and 300 twice a day also. But with 200 they say we will be able to achieve. And when it comes to combination, mostly the other antioxidants also the ideal dosage they combine and give. So if it is 200 with other antioxidants, I think it should do the serve the purpose.
But they say actually.
Yes, sir.
But they say that even you give QQ for 3 months, OD dose, that is enough without the combination. What is your idea about it now?
Sir, it is not. We cannot say only CoQ will work and other things doesn't work. When we, it is like, we need to individualize the patients, I would say. And when we see the patient has already undergone so many issues, and then when we have to give something which would benefit, in that case, combination would work better with the ideal dosage of CoQ. So I wouldn't say only CoQ should be provided. So, but if at all, if you see a young couple who are trying for a natural pregnancy, or they are all their investigations are normal, they are like an unexplained. So a single molecule of CoQ for 3 months should help them, and ideally encourage them for their natural conception also.
See, there is another group of people who say that antioxidants, when you give it in a combination, you can't be giving it them for more than 8 to 12 weeks, right? Because it has got other side effects if you're going to give them for a longer duration. Whereas if you give them CoQ alone as a single drug of choice, maybe it is probably could be safe to give even for a longer duration.
And also they say once you stop the drug, the effect is not going to be there. So we need to choose the patients, and if at all we are going to prime them prior IVF for before we take them for IVF, we can give for a period of 3 to 6 months.
I think patients should have patience, and doctors also should have patience to leave them alone for about 3 to 6 months without any interference.
True, ma'am.
So, just to reiterate, ma'am, or add any value about coenzyme Q10, like in female, it is recommended, like for safety issue, it's up to 1200 milligram per day, it's safe. So, not an issue about that. In female, it's mostly studied it's at a dose of 300 twice daily. With varied doses as Dr. Mona has presented, 200 milligram thrice daily, 300 milligram twice daily. But up to 12 milligram per day, it's safe. And in male, yeah, mostly it's a combination kind of thing, which is used in male infertility to improve all the sperm parameters. So that's my observation across the studies and what I've seen in the literature.
Okay, Vikas. Thank you.
Thank you, ma'am.
Yeah. Shall we move on to the other, the dialogue?
Ma'am, just one question from my end. Like, yeah. So, anyone has used like melatonin in this kind of infertile patient, female infertile patient? Can anyone share the experience if they have used it? If none, then we can move forward. Or resveratrol?
Not to my thing. We haven't used melatonin, but we have heard it's beneficial in the oocyte quality and elderly women as well.
Okay, sure. Thanks.
Thank you, all the speakers. I'm Dr. Vasundhara Jagannathan. I'm the Medical Director of Sri Chakra Fertility. Thank you for the opportunity to be a part of this wonderful webinar. We all know that male infertility is on the rise and is equally important cause of subfertility or infertility like the female partner. And many of the patients would reach out to the gynecologist first or the family physician before even approaching the fertility consultant or the andrologist. So it's very important for the gynecologist to have an understanding of basics of male examination or history taking up to the advanced level so that we can do the best to our patients. So the next session is going to be a dialogue on what a gynecologist should know about male infertility. And in this dialogue, we have two experts, Dr. Kundavi Shankar Madam. She is the head of the department and senior consultant and fertility consultant at IRM Madras Medical Mission. She has got loads of accolades and awards to her credit. She has been a teacher and has been training lots of fellowship candidates in the field of reproductive medicine, and so many candidates pass out each year under her guidance. So she is an achiever of ISO award, Dronacharya Award from HR, and she's got many publications to her credit in reputed journals, and she's a well-known national and international speaker as well. Next, we have Dr. Karthikeyan. He is the, can we please put the CV, please, of Dr. Karthikeyan? Yeah. So Dr. Vilvapati S. Karthikeyan is a microsurgical andrologist and urologist at Apollo Hospitals. He has loads and loads of fellowships from various universities, and he is a member of various forums like Global Andrology Forum, and he's an editor of Men's Health Society of India. And he's got many achievements like Young Urology Fellowship 2019 and MIUC Traveling Fellowship Award, EU REP 2015 from Urological Society of India, and he has got many other gold medals to his credit. So without much delay, let us begin this dialogue session between Dr. Kundavi Madam and Dr. Karthikeyan. Over to you.
Thank you, Vasundhara, for that nice introduction. I think looking at Dr. Karthikeyan's CV this time today, I'm going to ask him all the basic ones so that the general guy, whoever is in the group, would benefit. Can I have the slides because I have some problems here?
Yeah, sure. Just wait a second.
Yeah. Karthikeyan, welcome to our group.
Good
and
evening.
Yeah, I think the gynecologist would benefit with your things as well. Slideshow. Next. Dr. Karthik, when do you start evaluating a male partner when he comes to you?
Yeah.
So nowadays we try to start the male factor evaluation along with the female factor evaluation, because as we have been seeing, there is a rise in the male fertility as well. So it is appropriate to start the evaluation of the male partner at least in the form of a semen analysis, at least as soon as the female partner also comes, and we start the examination and the evaluation, especially when the female partner is normal or the male partner also has other issues. Then it is more worthwhile to also simultaneously start evaluating the male partner. And also, based on the age of the male partner, it is better to start early if the male is beyond 30 years of age.
Suppose the male comes to you on his own. He's getting married, and he says that, I just wanted to make sure I'm all right. So what advice would you give, and what evaluation would you do for such partner, for a male person who's still not married, planning to get married in about a month's time?
So there are many men who come for premarital check nowadays. So we actually do a basic history. We ask them, do they have any concerns? Because many men, even though they are not worried about their fertility or worried about other issues, so we do a basic history. Their concerns are addressed. We do the examination and see if the testis and the passage is okay, if there is any varicocele. These are the basic things we do. And then especially if the male partner is beyond 30 years of age, or there are other risk factors, or if the male is very concerned, or he comes like he himself asks for a semen analysis, then we suggest a semen analysis. Otherwise, we give the option to the patient, that we tell them that there is an option to do a semen analysis. When do you want to consider it? So that is how we go
It's
towards
not
it.
mandatory that we do a semen analysis even before they come and before
Uh,
their
because
marriage.
yes, madam, we don't want to, like, even though semen analysis is indicated, it is like very difficult to convince the males sometimes to do a semen analysis. And what if it becomes abnormal? So there are some questions, especially with 1 month before marriage. That is a dilemma situation. So we give the idea to the patient, and we take their opinion. But if they are forthcoming, then we certainly do a semen analysis.
Okay. Next slide. How many days of abstinence would you really advise? Because there are a lot of variations. The WHO says 5 days, 7 days. There are people who will come and say, I just had to ejaculated the previous day. So what is your cutoff, and what would you advise a general gynae to go about?
So actually, when it comes to abstinence, again, there are multiple confusions. But the easiest thing is any abstinence less than 3 to 5 days is very good. And if the male is able to give a sample with even as low as 24 hours, that is very good, because that gives a very good answer about the semen report. As we go higher, okay, if it goes beyond 5 days, then probably the sperm parameters start dropping. So what we tell our patients is around 2 to 4 days. That is what we want. And if we are doing any special tests, or we are more concerned about motility, morphology, pus cells, then we go for a lesser abstinence. And for DNA fragmentation also, we want around say 24 to 36 hours. But we can, when they come for a fertility check or initial assessment, up to 7 days, we can take it as okay. Beyond 7 days, probably we need to repeat the test at another convenient time.
We have Dr. Ramesh Rajan here. His boss, Dr. Pandian, if I'm not mistaken, I remember hearing saying that whenever a person comes and says he wants to do, we can do it. Is that, am I right, Dr.
Yes,
Ramesh?
yes, ma'am. Actually, we do, ma'am. We just did a study for both fertile and infertile patients. The only we think there is a change in the volume of the semen sample, but the parameters remain same, ma'am. So we did a study with a single fertile man who was given around 44 weeks for about of thing. So we find that there is no difference in the parameters, ma'am. It was like comparable. Only the volume actually changes.
So when you see a high WBC count, what would you recommend a gynec?
So nowadays, when we see a lot of WBCs in the semen analysis, the immediate practice is to probably start antibiotics, or at least do a semen culture. But the most important thing would be to ask the patient what was the abstinence period. Because if the abstinence period, even though for the test was maybe 2 to 3 days, but if there was a very prolonged abstinence period of say 10 days, 15 days, 20 days before, maybe then the preceding weeks of the semen analysis, that's an important factor which can lead to increase in semen analysis. Second, so that is what I mentioned as recent frequency of the coitus. So if the frequency of the recent frequency of the coitus was not okay, that itself can lead to increased semen WBC. And the second thing is, if it is all the factors have been like we have taken the history, the semen analysis was done under good conditions, then probably the next thing would be to look for, say, any phimosis or any the symptoms we ask are burning sensation of urine and pain after ejaculation, and maybe on examination we see any epidermal tenderness and all those stuff. So when we see WBCs, our idea is to first rule out any basics like was the sample collected properly, and second thing, if everything was correct, then we do a general examination and ask for specific symptoms. So these are the first two things we do, and then probably we can go for a semen culture or a prostatic massage culture.
Yeah, we have been doing semen culture routinely the last 20 years. I think very rarely we have found from infection. And you rightly said that if they had infection, a prostatic massage would be better than routine. Because there are a few IVF centers who would give regular antibiotics for men if they had this WBCs on the high side. But we know that you recommend for a prostatic massages, right?
Yes.
And what could be the cause for the recurrent infection, if you could tell us?
Ma'am, actually, if we go by semen culture, probably there could be nothing. It is then the semen culture is coming repeatedly positive. That doesn't carry that much significance. However, if the prostatic massage culture is coming significant, like it repeatedly, it is positive, say 2 or 3 times, or we find pustules more on the urine, then we go into little more depth. We ask for constipation, we ask for the lower urinary tract symptoms, we may do uroflowmetry. These are the things which may help us to identify why this thing is happening. And whenever we see a positive prostatic massage culture with the right antibiotic based on the culture, plus maybe probiotics, alpha blockers if the flow is low, and then to do frequent ejaculation. So these are the things which we follow. And if there is constipation, we treat it because we see some infections like Pseudomonas or Burkholderia. There are some infections like this which are notorious to be found only when there is some risk factor like constipation, or rarely say some spinal cord issues. So we are now trying to identify if there is anything specific which is causing this. So if it is nothing specific, and it is only a semen culture based infection, then probably we give a short course of antibiotics, especially if the patient is going for a procedure. Otherwise, we just ask them to do frequent ejaculations. We do the other things like antioxidants, probiotics, and review after, say, 6 weeks.
Last question from Dr. Vasundhara. When you know there's an infection, should we also look for a urine culture?
So maybe if the urine routine is normal, say around less than 5 pulses, probably most of the times urine culture doesn't add. So anyway, we are going to do a prostatic massage culture because we routinely don't do a semen culture. We go for prostatic massage culture. So at that situation, urine culture is not required. And we repeatedly see that urine cultures are negative and prostatic massage cultures are positive in this patient. So probably if the routine is normal, there is no immediate role for urine culture.
Like how patients are comfortable for the prostatic massage?
They're okay, madam. So we keep doing the procedure in OPD at least 3-4 patients every day. So they are okay with it. There are some people who are not okay, but most of the time they are okay.
Okay. Next slide.
Sir, madam, I would want
Yes,
to
yes, Mona. Yes, Mona.
Sir, this presence of pustules, sometimes I feel that these are there particularly if there are immature cells, if the are lots of aggregation, and I attribute it to that rather than actually infection. They are there to remove those immature cells from the semen rather than adding to infection. So
Yeah,
there is a place where you give them anti-inflammatory and then that clears away. That is the second point. So, long term and anti inflammatory. So, there are recommendations where Maggie is treated with anti inflammatory for, say, 1 month or something. So, do you recommend those treatments for them? Sir?
Actually, madam, what you brought up is very important, especially for the gynecologists and the basic like urology consultants who are going to do this work. So it's important to note that only the leukocytes have been, it's a leukocyte that has to be confirmed. It is not immature germ cell, etc. That has to be confirmed by the peroxidase test, and whatever we are talking about pus cells, what like usually we want is in a fertility unit, we are like very sure that it is only pus cell and not anything else. So the first step.
Yes.
So that is for the like the idea of the others. So once we are confirmed that it is pus cells, then what we go by is we see the number of pus cells. If it is more than 5 to 10, then it is probably an infection or inflammation. So if it is a prostatic massage culture negative, then it is not a usual infection. So it may be atypical infection. So we still go for some people go for doxycycline and all those stuff. So that is the given for a course. There are a variable period of 2 to 6 weeks which they follow. So we follow usually a maximum of 2 to 3 weeks. We don't go beyond that. Our idea is we still consider that a frequent ejaculation and frequent sex can actually improve this condition. There are some situations where, despite doing all these things, the pus cells are still high. That is where the concept of seminal inflammation and ROS and all those things, which we discussed in the two presentations, that is the thing which comes at that point of time. So, what we do for leukocytospermia is we first see whether it is really a leukocytospermia. Then we do a prostatic massage culture, see whether it is infection or inflammation. As you mentioned, we also, in some patients, we do a anti-inflammatory treatment also. And we also see that alpha blockers help. So either alpha-zocin or tamsulosin also help, especially when the flow is borderline.
Ma'am, I have a small doubt. When we prescribe antibiotics for these routinely, should we prescribe probiotics? And if so, what probiotics do you recommend?
Yeah, so nowadays we are just into the concept of treating prostatitis with probiotics, especially when it is infectious and when we have treated the infection and if it is becoming still inflammatory, then there is a role for probiotics. We do have some seminal specific probiotics which are coming up, but any probiotic for that matter is okay because we have a lot of combinations. So like we discussed antioxidants, there is never ending discussion about probiotics. So the only thing here is the probiotic dose should be longer, and again the stress is on the frequent ejaculations rather than the medicines.
Next slide. Suppose you see that when there are no sperms in the semen analysis, like how do you go about when the patient comes to you, Dr.
So the first very important thing here is, was the sample processed properly? So before going to the processing, was there any difficulty in sample collection? Is it the semen only? What is the pH and all those things? Those are important. And second thing is when we see that there are no sperms in the sample, we actually request the embryologist or the lab technician to centrifuge the sample and examine a pellet to confirm that there is no sperm. So this basic difference between azoospermia and cryptospermia. And second thing is, whenever we see that there are no sperms, then again we see what is the volume, what is the fructose, and what is the pH to help us like have some more details about it. And also we, as andrologists, we try to correlate what is the examination finding and what is the semen analysis report. So, for example, if there is a very small testis and the semen analysis shows no sperm, it is probably correct. But if the testis is normal, especially with the palpable vas, maybe there is some error which can be identified. So, when we do first semen analysis and if it is abnormal, like there are no sperms, then basics would be to centrifuge the sample and see and correlate with the clinical parameters. Probably that is the first approach. And then, of course, ask for a repeat sample.
If I could ask you a basic question, like we do a pelvic examination for all women when they come to us. So before you order for a semen analysis, would you check the male partner, then you ask for the semen analysis, or the semen analysis, then the examination comes?
In an ideal situation, examination first followed by semen analysis, but we always get the report before we do the examination.
Okay. So when you see this abnormal report, so when do you really ask your male partner to repeat it?
Actually, if it is again clinically indicated, we know that it is going to be azoospermia only, then there is no point in waiting. We want to do the treatment as quickly. So maybe in the next 2-3 days itself, because it's based on the where the location of the patient, all those things also. But in ideal circumstances, maybe 4 to 5 days or 7 days is okay. Otherwise, we repeat it as early, at least around 1.5 to 3 days of abstinence, so that we get a correct sample. We also are very concerned about whether the patient was able to collect the sample correctly. So we ask him whether he knows to take a sample, whether he is able to collect the sample in the lab. So all those things are rechecked, and when they go for the second sample, we try to reduce the number of reasons for a say improper sample. So that is what we focus more on. And when we see a azoospermia patient with a clinically relevant situation, we also add hormones to the semen analysis that can guide us better.
Karthik, again, I'm asking this question because we're running, Mona and ourselves are running the fellowship program. So do you think we make it as a consensus or a mandatory that they also should learn how to examine a male partner? Then you ask for a semen analysis, what we do for women.
Yes, madam.
Is that all right?
Yeah, fertility consultants, I think we have to, at least basics examination has to be done. So starting from whether there is a phimosis, what is the testicular volume, is the vas palpable and varicocele, at least these four things. And if epidermal fullness, if we can make out the epidermal fullness as an examination, that will also add value to the examination. So these are the things where examination still plays a very vital role. And as fertility consultants, they should be like, at least this part they can focus on learning.
Now, one thing what we found is when we were doing a fellowship in CMC Vellore, the men are more shy when compared to a woman. A male gynecologist could examine a woman, but a female gynecologist, when they examine a male partner, they tend to shy away and they're not comfortable while examining as such. So it's the real world. So move on to the next slide. So when you have a person who comes with a low volume, so what would be a next step to it?
So again, when we see when we read a sample, it's a little different, and when we examine, we are going to look for additional things, and finally, it is all a combination of all these things. So whenever we see low volume, the first thing is what is low volume. So based on the WHO 6, we say that around less than 1.4, like we have a cutoff, but whatever we discuss, like whenever we discuss about low volume, it is always 0.5 to 1 ml. That is called as low volume. That is because in this situation, there are either real causes or false causes for this low volume. So whenever there is a low volume, say especially less than 0.5 to 1 ml, the first question, as I told just before also, is whether the sample collection was correct, whether there was a difficulty, whether there was any spillage, how was it collected, was it by masturbation or by coitus interruptus, and whether we can also ask the couple whether always is this the low volume of semen which you see, or at this point of time it was low. So again, when we see a low volume, if the semen volume is more than 1 ml, then probably it is still okay. But if it is less than 1 ml, then that particular thing of difficulty in sample collection is very important. The second thing is, if it is a persistently low volume, we see multiple reports, everything is say less than 0.5 ml, then we typically examine the patient to look for vas deferens and epidermal fullness. So these are some important things. And we also ask them if there is any ejaculatory dysfunction. So those are the main things which we can focus when we see low volume semen.
Suppose if the report says it's a viscous sample, so what would you ask, and then how do you go about it actually?
So viscous samples and this leukocytospermia, the approach to a sample is almost similar. So again, abstinence is the first thing which we ask for, and second thing is to look for any inflammation. And the last thing would be like whenever we have a block, for example, congenital bilateral absent vas, the sample is typically very viscous. So these are the basics which run in our mind when we see the report as a highly viscous sample. Also, when they report it as viscous, there are multiple things like, was the sample processed properly? Did the person in the lab know whether the viscosity is like this is how it is processed? All those things also matter, especially when it is done outside the fertility unit. So if it is done in a fertility unit, we are sure that most of the things are we know about our lab. So like we can be sure that yes, this is a viscous sample. But when the viscous sample has been reported in some other place, it is best to repeat it. So these are also important points because that is how the management depends upon.
Dr. Ramesh, you are here?
Yes, ma'am, I'm here.
Ramesh, being an embryologist, if you see a viscous sample, what would you do and what would you tell the gynec from your point of view?
Usually, if there is a viscous sample during semen analysis, actually we can do a syringing and we can do the scene analysis now. If it is for IUI, actually we can, mix the sperm media, pre-incubator, and we can start preparing. Once we see the viscous sample in the, during the routine scene analysis, usually we'll inform the patient. As sir actually correctly said that there is abscess is much more important, one thing, or any urogenital inflammation is important. These two things we need to rule out. But usually we say if it is more, the viscosity is, if you're just putting a drop from the pipette, usually there will be a string-like thing that is called actually viscous one. So we usually inform the clinician saying that the viscosity is more, and we use the syringe for doing the semen analysis. So this then they will guide the patient and they'll start asking about the underlying causes.
Does it have an impact on your numbers and the motility and morphology?
If it is viscous, definitely there will be a decrease in the motility because of the viscous one. Once the viscosity is released, you can able to see the motile spermatozoa will be more and compared to the non-viscous happening.
Okay.
But
next slide.
Actually, one important thing here would be probably the sample is viscous, but it is not always mandatory that it is the same thing which is happening in vivo. So this is an in vitro testing. So that point also has to be remembered. However, when there has been a long duration of infertility, then probably going on for processing the sample and going for IUI are the next options, because we don't have other options. Viscosity is very difficult to treat at times. So just that the sample is viscous doesn't make the couple infertile. But it is just to remember that if nothing is working, then probably that is the cause.
Just adding on the practical point on this thing, ma'am. Sometimes the patient will collect the sample and keep the sample on the AC room. If it is very cold, also the viscosity remains it could be prolonged, ma'am. As soon as you get the sample, put it in the 37 degree. This will help you to rule out whether the viscosity is due to the patient problem or the environmental.
Okay, I think that's a good point. Then your andrology room should be at the room temperature, not at the freezing temperature, is it?
The handling, the container is important, ma'am. Actually, even if it is a very cold container or anything, that will actually impact the sample to be very viscous.
Okay. Dr. Karthik, what hormone evaluations would you recommend, and why would you recommend, and when do you recommend?
So if we go stepwise, then we go for first is FSH and then is testosterone, and other hormones come after that. But as a practice, we always ask for 4 hormones like LH, FSH, testosterone, and nowadays we are also adding estradiol. And there are many places where prolactin also is added. But then
thyroid is also been added.
Ma'am?
Thyroid,
yeah. So whenever we ask for hormones, the basic idea is how is the HPG axis. So whether the testis is at fault or pituitary is at fault. So that is what we want to identify. And basically, when the concentration is around 10 to 12 million or less, then probably it's the role for hormone evaluation. Also, hormone evaluation depends upon what is the testicular size. If the testis is normal and the concentration is more than say 12 to 15 million, then probably initial hormone evaluation will usually return as normal. So the clinical significance is questionable. The relevance is also questionable. However, if we are considering that there is either hypogonadism, or if we also consider that the testicular size is small because of any reason, then probably hormonal evaluation is the next step. So where we ask for the FSH and the testosterone first. But as I said, we ask for the 4 hormones to see how is the HPG axis, whether there is any testicular failure, or is there a pituitary problem where the pituitary is less functioning, especially in a hypogonadism situation, which is a little rare. So usually what we get is the FSH guides us towards what is the probable cause, and the testosterone helps us to identify whether there is any role for doing hormonal manipulation.
And Dr. Karthik, Dr. Ranjit Ramaswamy, we've just had some papers saying that instead of doing a total testosterone, we can do a 17 OHP. So what is your take on that?
So we are now routinely using 17 OHP because I trained under Dr. Ranjit, and I was at Miami when that study was going on. So in 2019, that is the time when this came into the work. So we use 17 OHP and we find that it helps us. However, the real cutoff of 17 OHP, which is by Dr. Ranjit mentioned as 55, but we go up to 1. We keep it relaxed up to 1. We keep that is the reason for that is probably because to give the benefit to the patient. So when the testosterone is in the border, say around 300 to 400, but the testis is small and FSH is normal, we use the 17-OHP as a second marker to identify the intratesticular testosterone. So we all know that more than the peripheral testosterone, the intratesticular testosterone is more important. And in the search of a marker for the intratesticular testosterone, 17-OHP evolved. Otherwise, it is very cumbersome to test the intratesticular testosterone. It is possible only by invasive procedure. So 17-OHP came in that way, like it can be a surrogate marker for intratesticular testosterone. So our idea is whenever the 17-OHP is less than 0.5, that is the indication to add, say, gonadotrophins, and if the E2 is high, then we add anastrozole. Otherwise, it is in a way we use 17-OHP to rule out hypogonadism, especially intratesticular, when we are confused and if there is less time and all those things. If the 17-OHP is well above 1, then probably it means that there is no much role, everything is already okay, and it's a testicular failure which is the cause, and probably move on with the treatment instead of wasting time.
Does it have a correlation between FSH? Then you talk about testicular failure.
And the question is, does FSH have a correlation with testicular failure?
So 17-OHP.
No, madam. At many times, probably the testicular failure for spermatogenesis is only for the sperms, and the hormones are very good. So the testosterone may be very normal, but the sperms are not okay. So that is a specific genetic defect which we are now understanding. So probably the correlation happens only when both the things are damaged at the same time. Other than that, I think the testosterone part and the testicular failure part are little, they are not always overlapping, especially when it is genetic.
Next slide. So when would you offer a genetic testing? Do we give it for everyone or only for certain patients?
So as per the guidelines, whenever it is less than 10 million, we go for genetic testing. However, in our practice, we definitely start doing genetic testing when it is less than 5 million, or let us say severe oligospermia or azoospermia. The other indication for genetic testing is also when there is bilateral absent vas for like a CFTR gene mutation. We also have something called a genetic panel which is upcoming that helps us in some clinical situations, like when there is a varicocele with say low sperm count or azoospermia, very low counts, or varicocele having, say, there is varicocele also and there is isolated say absolute astenospermia, etc., or when there has been a treatment and failure. These are the newer indications for the genetic panel. However, the conventional karyotyping Y chromosome microdeletion is done when there is a production defect, that is a sperm like less than 5 million or azoospermia. And for the passage, like the absent vas, we do the CFTR gene. These are the three important tests. And CFTR is always a whole gene sequencing.
We're talking about the genetic panel, right? What are those things involved in that panel?
Madam,
it's like a package or something?
Yeah, it is something like a whole exome sequence, but mainly aimed at only the reproductive genes. So it's a next generation sequencing test. Presently, it's available only with 2-3 labs. So this test actually is a AI-based test where they sequentially they exclude the like possible reasons for this sperm production defect. So what we get to know here is whether there is only a spermatogenesis defect or there is a genetic defect for motility, morphology, sometimes sperm DNA fragmentation. These things we come to know. So recently we had a patient where the count is 9 million, but the progressive motility is 0%. So whenever we see an absolute or a very low progressive motility less than 5 to 10%, we are constantly now getting positive results, like whenever there is absolute astenospermia or very fixed like less than 10% progressive, we are getting mutations like catsperone, etc., which are positive. So this clearly gives us an idea that only the motility is at fault and maybe the production is not at fault. So in that situation, an ICSI is favorable. Similarly, we see many patients who come with a very good count and absolute like 0% progressive motility. Again, we do the trust scan, all those things we do, but nothing clinches the diagnosis. When we do this panel, we get the answer. But this particular patient, which I told that 9 million and 0% progressive, he also had a ESR1 mutation, which we saw, that is responsible for impaired spermatogenesis. So our answer is very clear that he has a genetic problem of spermatogenesis also and a genetic defect for motility also. So if it was only motility issue, the results of the ICSI would be very good. But if the production defect is also there, it obviously reduces the overall success of IVF. So Up to this level, now we are able to counsel the patients, even though it's very, very like in the beginning phases, we are using it in the last 2 years. The data is yet to come up, but we are getting the information about these things, especially in difficult situations.
It's a blood, right? Not on the sperms.
Blood, madam.
Blood. Okay. And if it is absent vast difference, then probably CFTR only for male, or you do it for a couple as such?
Madam, if the male, first we test the male. If the male CFTR whole gene sequence is negative, we stop there. If it is positive, then we test the corresponding. We have to test the corresponding allele, but then we do a complete CFTR for the wife also, so that we save time.
Okay. And what about the ultrasound? Do we really, because we have seen most of them have a report with the next slide with the scrotal ultrasound. So, do you recommend the general gynae to do a scrotal ultrasound?
So, ma'am, when we were discussing about the fellowship, we were discussing that. Next slide, please. Yeah. So, like if either the doctor or the patient is not comfortable for physical examination, then probably it's an indication for ultrasound. Otherwise, ultrasound is not routinely recommended, only for the fact that it may overdiagnose some things. So there is new confusion added that there is a subclinical varicocele, and which was not thought about because it was not clinically significant, and all those things come into the picture. Really, if an ultrasound is recommended, is only in very specific situations like a tight scrotum where we are not able to feel the cord, or the patient is obese, so making examination difficult, or sometimes the patient feels very uncomfortable for examination. Now this is a very increasing trend now. Men don't want to be examined even by male doctors. So that is a situation where we are in, and it is going to rise only. So these are the situations where we do the ultrasound. Probably one more indication to be added is patient choice. So before we even ask for an ultrasound, nowadays patients get the ultrasound done. So that also comes into the picture. That confuses the picture further. Other than that, for a varicocele, the classical teaching still in the andrology community is don't do an ultrasound, especially if it's a clinically palpable varicocele. But again, when we see varicocele, due to the like increasing confusion about the varicocele, there are there is lot of research and evidence about a subclinical varicocele which is subclinical, which becomes big after the first site, like the prominent site being operated. 6 months later, the other side becoming big. All those things make us do ultrasound for identifying subclinical varicocele. Otherwise, like a basic, say 10 million count, 20% motility for a favorable patient, probably doing an ultrasound to confirm the varicocele is not required when the clinical examination is confirmatory. The next thing is, again, when it comes to bilateral absent vas difference, a transrectal ultrasound is not required to confirm the diagnosis because, again, CBVD is a clinical diagnosis. However, in the modern era, probably to confirm varicocele and to confirm CBVD, we can do a scan. Otherwise, just doing a scan for completion purpose may not be a suitable option.
Okay.
So
next slide.
Suddenly we see sperm DFI being elevated. Then the doctors start doing the ultrasound scrotum to find out a subclinical varicocele. Those are not indicated. However, if we don't know like why this is happening, at that time doing ultrasound will confuse the picture. So that is what the take home.
So when a patient comes to the clinic and he's not able to produce the sample on demand, so what would you advise the gynec person?
So again, nowadays this is becoming an increasingly difficult situation because there are multiple factors operating in the mind of the male. So sometimes they come and say that they don't know to collect a sample. Sometimes they are more addicted towards some different things like porn, etc. So it's very difficult for them to come to the real world and give a sample. Sometimes many of them are very anxious, especially when they come for the first time, knowing that the female is completely normal. They may not ready to take the blame, so that is a very stressful situation for the male partner. They are not able to give a sample, and there are some situations where we go deeply and ask them what are the what could help him giving a sample. So when he is not able to give a sample, the first point is why he is not able to give a sample, and the second thing is if he is not able to give, what could help him to give. So again we ask them, is it possible at all for you to give a sample or not? Do you want your partner to be with you? And would you be okay with home collection? So these are all the things which we ask stepwise to identify where is the exact issue, and probably around 75 to 80% we succeed in making them give a sample, at least by home collection.
We were talking about sildenafil. So, what are the best drugs, the latest ones available for a male partner, and how safe they are? Should we really get into the history of diabetes, hypertension, and all this stuff, because people think certain drugs could not be given to them?
Yeah. So, when it comes to PDE5 inhibitors, the only question to be asked is probably, are you on nitrates? So if the patient is not on concomitant nitrates, then it almost rules out that there is no probable problem in the patient which can lead to a complication. Because if there is no nitrate, then CAD is ruled out. If there is no nitrate, again the coronary artery disease severity will be less, even if it exists. Otherwise, we know the comorbid conditions of the patient. We know what medicines they are taking. So in that situation, probably there is no problem to give the drug in the hospital. Next thing is whether sildenafil is useful, even though traditionally sildenafil has been practiced. Sildenafil for a normal person can delay the ejaculation. So if a normal person who is not able to give a sample, giving sildenafil may still confuse, like it may still worsen the situation. What happens is when they take sildenafil, because it can also work for premature ejaculation. So sildenafil actually delays the ejaculation in normal men, and they are not able to give a sample. So now the newer drug, which is avanafil, is probably better in this situation. It is the delayed ejaculation with avanafil is less. The other problem with sildenafil is headache. Again, with avanafil it is less. So instead of the 100 mg sildenafil, which is routinely practiced, we can actually give 100 mg avanafil, which is a better choice for this particular situation. And if at all it is sildenafil, maybe if the person is otherwise completely normal, 25 to 50 mg is better than 100 mg. So these are the updates about what drug can be used at that point of time. But nothing works like counseling. However, it is very difficult to counsel the male at that point of time, especially in the ART cycle or IUI. So it will be a difficult situation. Probably it has to be anticipated these days.
Next slide. So, how early do you advise them to take that tablet avanafil even before the sex?
Ma'am, avanafil, even though they market 15 to 20 minutes, it is a short-acting drug. That's what the pharmacokinetics is. However, we find that taking the drug around 1 hour before is actually beneficial, and it works better. Because there are multiple other things like foreplay, etc., which are also required. So for sex as such, giving the drug around 1 hour before is ideal. In the clinic, if there is a difficulty in sample collection, the patient can start collecting the sample as early as 30 minutes after taking the drug.
And there was one patient who said that sex is not possible, but I can masturbate and produce a sample. In such situation, what you do? He says, I can masturbate, produce a sample, but I'm not able to have sex with my wife.
Yes, madam. So that is the whole confusion, whether it is erectile dysfunction or ejaculatory dysfunction. So we again start discussing with the patient first, what is the exact issue, what is happening. So when you're doing masturbation, what are all the things which you concentrate on? How do you get the interest to do masturbation? What do you watch? All those things we ask. Second thing is when it comes to the erection assessment as such, we ask them whether there is a difficulty in maintaining the erection. That is many times that is the reason for anejaculation intravaginally. The third thing is there is something called delayed ejaculation or anejaculation, which is a complex problem for which we need a detailed assessment. So when somebody is able to have when is able to give a sample by masturbation but not have penetrative intercourse, or by not being able to ejaculate intravaginally, it requires some time for us to understand what is the basic reason, and based on that we can manage the situation.
I had a very interesting person who said that he just came to us, and as routine when we gave the seminars, he could masturbate and produce a sample. But when I was going into the history, he said, Doctor, when I'm having sex, there is no ejaculate coming. So I really didn't understand where the problem is, because it's easy for us to do an IUI and make them pregnant, but he's not able to enjoy his sex with him. So how do we go about it actually?
Yes, madam. So this is typically the situational ejaculation, where this can be for anything. So it can be for giving a sample also. It can be for giving during sex also. So when he's not able to ejaculate intravaginally during sex, it is easier for us because, as you told, we can finish with an IUI and at least the fertility process is completed. Again, this is a complex situation. Whenever there is an ejaculatory problem, be it premature, be it delayed or an ejaculation, it is always very complex when compared to ED, because ejaculatory problems by themselves are difficult to diagnose and treat. We know that premature ejaculation, we see many patients, so we get the idea easily how to manage it. And if we treat erectile dysfunction, we give some medicines, the premature ejaculation becomes okay. But when it comes to delayed ejaculation, there are multiple things. Is it always an ejaculation, or is it situational an ejaculation? If he is able to produce a sample and do a semen analysis, then it clears our confusion. So he is able to masturbate, the axis is intact, the anatomy is intact, there is no problem. But if he is unable to give a sample for SA, then the confusion starts. And if we go deep in the history and ask if he has never done masturbation in his life, he has never seen the ejaculate coming out, then it's a real confusion. We don't know where is the problem. That takes a long time to treat them. Again, when we see a difficulty in sex but able to give a sample, while we make the couple undergo IUI and if the fertility concerns are addressed, then probably the patient starts becoming better. That anxiety goes off from the mind, and then they are probably able to do the penetrative intercourse successfully. But then this is a complex problem which I think will require a separate session, madam.
Okay. Next slide. Because I was really finding it difficult to counsel him actually. He says, "Ma'am, I'm not able to ejaculate, but I could masturbate," and the sample things was like, when we're doing this DF, yes, Mona.
No, ma'am.
Kasundra here. Sorry to disturb you. I had a couple of patients like this when you were mentioning such a difficult situation when they say that they're not able to have sex with their partner, but they're able to masturbate and produce a semen. And most of the times when I ask questions, and sometimes it is love marriage for the couple, it's not something that, they're not compatible with each other or they didn't know each other before. The main thing is, in few cases, I found that they're addicted to pornography and other things even before their marriage, and they are having over realistic expectations from their partners, and they're not able to really perform the sexual intercourse with the wife. So I think the deeper things to this, rather than maybe ejaculation problems, also is what I feel, ma'am.
I had a patient who said that I'm comfortable with another woman, not with my wife. So that's when we were a little shocked, and he never had a sexual relationship with his wife. So, and probably when they have attraction towards the same group, I think certain history we should go into the depth and probably ask them to.
Actually, madam, he is able to give a sample for analysis. Our situation is actually better. Rather than the patient able to have intravaginal successful ejaculation and not able to give a sample is more confusing and difficult. So I think the situation is a better situation when compared to like the other one where the fertility treatment becomes a problem, because by the time they reach us, they are almost very stressed. And on top of that, if he's not able to give a sample, then probably nowadays we are seeing patients where only sperm retrieval is an option. Because last 2 days we have had 2 patients in whom nothing can be done other than like a sperm retrieval procedure. After adequate counseling, therapy, wife becoming aged, all those things are now happening. So this particular situation which we discussed is a better situation, at least for the fertility concerns. At least for
do you have any special vibrators just which works at the penile, like a small battery thing, or you have a bigger instrument as a vibrator?
So earlier what was available is only the massages which we are using. Nowadays also we are using the massages more commonly because that is easily available on Amazon also. But we do have medical vibrators which are like Vibrect, and we have one more imported one. So these two are presently not widely available in India. So we now use some hand massages which are available on Amazon for around 2,000 rupees. The ideal vibrator, the principle is it has to give continuous high amplitude, high frequency stimulation to the glands. So that is the principle. Whichever vibrator fits into that probably is okay.
I think because sometimes men are not comfortable with the special condoms. And I think as of now, the special condoms are also not available, if I'm not mistaken. So how frequently yes, Dr. Karthik.
Yes, madam. The non-spermicidal condom availability is also a little restricted, but we have 1 or 2 companies supplying it.
Okay, because I was told latest we use the Krishko and he said it's not available. So maybe I should talk to you for that. The DFI. So, do you recommend for all men or only for certain men? Do you recommend? If so, like any other treatment, would you advise them?
Again, DFI, as we discussed just now in the presentation also, it is not the first line investigation whatsoever. So the DFI, the evaluation and the treatment of DFI is still evolving. So we don't have exact guidelines about DFI. However, now we are a little more clear as to when to do DFI. So the indications specifically for DFI are whenever there is a idiopathic, like when the parameters are reasonably okay, sometimes the couple is not conceiving, or when an IVF has failed or IVF is not working, or whenever there is a varicocele with near normal parameters despite medicines, if the all other things have been ruled out, these are probably the very important indications where DFI is presently used. However, what is the exact role of DFI, like when to really go for DFI testing, these are all still not very clear. And in many centers nowadays, unfortunately, DFI is being practiced very widely. So the most important, let us say, the most important checklist kind of things to do a DFI is the patient, that is the husband, should have had regular intercourse or regular ejaculation for at least 4 to 6 weeks before the DFI test. And we also, since DFI being a costly test, we actually start the patient on antioxidants for at least 6 weeks, probiotics if there are puzzles and all those additional points. And if the semen analysis is not normosospermia, we also add antioxidants before we go for DFI. Of course, we also rule out the varicocele before doing the DFI. These are, like in a nutshell, these are all the things which we follow for DFI. And again, as I told, a very short abstinence period for the DFI testing.
Being a urologist, would you recommend a testicular biopsy or ejaculated sperms if the DFI is very high, or your experience on a varicocele surgery and a DFI?
Ma'am, actually, there are two questions here. So, if the DFI is high, idiopathic, like there is no other cause, then is there a role for testicular biopsy? Till maybe around 6 to 8 months back, we were also considering the testicular biopsy. However, a recent paper which showed that the results are almost comparable probably makes us believe that there is no major difference between a testicular sperm and ejaculated sperm. However, if it's a second IVF or third IVF where the DFI is above 50 to 60%, then probably it makes it a worthwhile opportunity to do a testicular biopsy and at least do 50% ejaculated sperm, 50% testicular sperm, because there is no other way to improve the success at that point of time if there is no other way. So that is one thing about testicular biopsy in elevated DFI. Second thing, when it comes to varicocele, if there is POTS plus elevated DFI, at that point probably a DFI was not required to be done. But if it is normosospermia with large palpable varicocele with elevated DFI, if all the other parameters have been ruled out, all the measures for reducing DFI have not been useful, then probably that is the situation where varicocele repair may help.
Okay, normal sperms, high DFI, you would recommend
once all the other factors have been ruled out, all the trials have not been fruitful.
I'm happy as a urologist you're giving us this answer. We have started using 1 day abstinence and second ejaculate, and we found that the sperms were better with the second ejaculate. Moving on, next slide. I think
However,
probably one.
Concept of second ejaculate for DFI, we don't know how far it is okay, because we are not testing. The DFI happens actually, the time for the DNA fragmentation to go up is actually high. Maybe the more frequent ejaculations before the ART cycle will probably be a better choice, because what happens is when the IVF cycle starts or the evaluation for IVF starts, they stop having sex.
Yes.
So that is one important thing probably will be useful to practice.
I would tell the husband to ejaculate frequently rather than having sex. So, and I tell them, and I also ask one question: how comfortable they are by giving 1 day abstinence, because men get stressed out, not able to give the sample. Then invariably we have to do a testicular biopsy on the day of collection.
Especially when we are doing DFA, always the sample is less than 0.5 ml for many people.
Coming to the obstructive and non, what is the medical management, the recent medical management you would advise them?
Ma'am, when we are very clear about the diagnosis of obstructive azoospermia, then if the blood reports are normal, testicular volume normal, no varicocele, there is actually no role for medical treatment. However, whenever they are going for a IVF cycle, we usually add antioxidants. So that's we can add a very low dose of antioxidants, where even 100 mg of coenzyme, multiple components, but maximum coenzyme which is required at that point is maximum 100 or 200 mg. Nowadays, we see overlapping non-obstructive and obstructive. Sometimes the picture appears to be very clearly obstructive, but when we do a, say, surgical sperm retrieval, the sperm quality is not okay. So because of that, we probably add antioxidants to this patient, because we are it is very difficult to pinpoint that this is the level of the obstruction and this is obstructive or non-obstructive, even though testicular volume and FSH may be very normal. So most of the times we are not very, even though we are able to have all the parameters suggesting an obstructive azoospermia, we are still not very clear. So this is one more place where the genetic panel is picking up. If we do a genetic panel in this situation, and if it comes as a sperm production defect, then probably it's not an obstructive anymore. It is probably non-obstructive, and we treat it as non-obstructive. It also helps us in prognosticating the IVF outcome. So coming to non-obstructive, so in non-obstructive, again, is it a hypogonadism or a hypergonadotrophic hypogonadism, like a hypogonadotrophic hypogonadism or hypergonadotrophic hypogonadism? If it is hypergonadotrophic, again, genetics and sperm retrieval are the only solutions. If it is hypo, where the LH and FSH is less than 2 plus testosterone less than 300, that is where we can do a prolonged medical therapy with HCG and HMG. And if the FSH and LH are in the range, that is in the eugonadotrophic level, then it is only a trial for 3 to 6 months. So this is the basic idea about how do we go about azoospermia with, say, based on the testosterone and the FSH and LH reports.
If I'm not mistaken, Dr. Ranjit again said if you have a testosterone deficiency or something, you treat them and then you start with the medical management. So how do you explain that situation then?
Ma'am, exactly, like if there is a testosterone deficiency, how to go about it?
Yeah.
Okay. So if the FSH is more than 10, that is 8 to 10, then it is probably, as we mentioned, we are able to understand that it is more genetic in origin. So at that point, if we wait to correct the testosterone levels, which may not be helpful, we may be losing whatever sperms are available. So yeah, a good advice would be to see the testicular size, the FSH report. If the FSH is sky high, more than 15, more than 20, there is absolutely no role to wait. If the FSH is around 2 to 8, which is mentioned there, that is the window where we have a hope to improve the whatever sperm we are getting. However, there is something called, like, I think the question is how to optimize before surgical sperm retrieval. So to optimize before surgical sperm retrieval happens only when the LH and FSH are less than 10. Beyond 10, probably it is we are racing against time and we have to go for sperm retrieval first. If we did not get any sperms in the sperm retrieval operation, from there we have to see how next to proceed. So at that time comes all the medical therapy, advanced genetics, and discussion about donor sperm. All those things come there. If the FSH is less than 8, then probably we can do some trial for 3 to 6 months, because till that time also we don't really know whether this HCG is going to work or not. So we don't have anything to guide us.
I think some case report for non-obstructive by Ranjit saying that in Klinefelter's giving a letrozole or an anastrozole did have an improvement in the semen parameters. So
that's a very unique, yes, madam. That's a very unique situation which is applicable only to Klinefelter. So that's why I thought that is not that's only a very unique indication. That is the only situation where medical therapy works. If the karyotyping is normal, if the Y chromosome is normal, as I mentioned, these genetic panels are in up to 99%. We are getting positive results. So we are able to at least understand the background of the disease. So probably we are beginning to realize that there is no role for preoperative optimization of testosterone if the FSH is very high.
So who are the candidates? Can you just repeat once for the gynecologist, like for the genetic panel? Where would you tell them to have this genetic panel as such, rather than a routine karyotyping?
Ma'am, karyotyping we do for all patients, and ideally we do Y chromosome microdeletion for all patients. So the genetic panel is actually an advanced test which we don't want to do it in the first place. So a genetic panel comes much later, or if it is very specific. So probably in those situations, the patient has already reached the specialist. It's either the fertility expert or the andrologist. However, is there a routine indication for doing a genetic panel? It is probably not, because it's an evolving test, and we also don't know what is the exact implication of the test. Because we do the Y chromosome activation, we know the implication. If it is positive, it can get transmitted to them. All these things we know. But if an ESR1 or whatever mutation I mentioned, whether it will really go to the next generation, whether it requires any advanced testing, all those things, the answers are not still very clear. So as such, it is not okay to do a genetic panel in the first place. However, if there is a failed IVF, or if there is a doubt whether to do a varicocele repair for a non-obstructive or a severe OATS, or is there a specific defect like a motility disorder, morphology disorder, or very very high elevated DFA levels all the time, they are not coming down. These are probably some indications where like a gynecologist can order for this test. However, again, when the reports come, there is a confusion as to how to go about it. So it's better to refrain from doing the genetic panel. We also don't, we, even though we get so many patients where we can do the genetic panel, we are not doing them because it really confuses us. So if the patient is keen on either donor sperm or they're very keen on going for their own sperm, it actually doesn't make a difference. Only when it is going to change the treatment plan, probably that is a situation where this genetic panel will help. Example is when there is a very high FSH. If we identify a FSH receptor mutation on the genetic panel, probably if the first microdosy did not work, there is no sperm, then at that time when we are giving a long-term empirical gonadotrophin, instead of giving FSH, we can give recombinant FSH. That is the one or two very specific situations where the panel can alter the treatment. Similarly, when there is a high-grade varicocele, we don't know whether this varicocele is the reason for azoospermia or vice versa. At that time, again, whether to go for the repair or not, especially when the female partner doesn't have enough time. These are probably the specific indications where this panel can change the treatment. Otherwise, this panel is a very, very new thing and probably not the right time to start prescribing, because we still don't have the guidelines, madam.
Thank you, Dr. Kar. Maybe the last slide. So I think, how do you go about the retrograde ejaculation? Because we have already spoken about hypo.
Yeah, again, retrograde ejaculation is a specific diagnosis in a specific situation. So every time it cannot be retrograde ejaculation if it is an ejaculation or a reduced low volume ejaculate. Probably if there is no diabetes, no spinal cord injury, the diagnosis of retrograde ejaculation is not possible to make. That is the first thing. Second thing is how to diagnose retrograde ejaculation is we collect the urine after if the patient is unable to ejaculate, or if he is having low volume, then after the semen analysis or after the feeling of a semen release, that is orgasm, we immediately check the urine. So we collect the urine, we centrifuge it, and we look for under high power field how many, like in the pellet, how many sperms are there. If the number is more than 3 to 5, probably it is an indication that it is retrograde ejaculation. So that is the diagnosis of retrograde ejaculation. Similarly, when we have good number of sperms in a known patient of diabetes or spinal cord injury, then probably it is worthwhile to collect it and use for IUI. Otherwise, the role of testing for post-ejaculation urine is to confirm the presence of sperm. When we have anejaculation, azoospermia, in these situations, if the low volume, if the VAS is present, all those things, if we see sperms on the post-ejaculation urine, at least we know that sperm production is happening. Whenever it is a good volume of like good number of sperms in the urine, then we can try to retrieve it and use for IUI. And there are some drugs which can cause antegrade ejaculation, especially in say diabetes or neurological situation, which is daily imipramine up to 75 mg per day and pseudoephedrine 3 to 4 hours before the sample collection.
Yes, next slide.
I think that's good.
That's the last one. Yeah. Coming to the talking of the serodiscordant partners, like how do we go about Dr. Karthik?
Yeah, ma'am, it's a slightly difficult situation where we usually work in tandem with the fertility expert, because we are like, we don't do most of the things. We do only the diagnosis and we actually send to the fertility expert. So based on the serology, like if it is HBsAg and HCV, today for HBsAg, there is a real good treatment where we can reduce the viral load, simultaneously vaccinate the wife. Once she has become having protective titers, then we can go on. If it's a seropositive HIV, then probably there is treatment to reduce the viral load, and sperm preparation may help. So more of IUI and IVF things are probably what is practiced. I think you will be the better person to answer that one.
Dr. Ramesh is here, so probably what precautions would you take if you have a serodiscordant, Ramesh?
Any sample, we never know whether it is a biologically, non-infected sample. So each and every sample which do for semences, we follow a proper protocol in doing it. If it is a serodiscordant, if it is positive sample, definitely we'll go ahead with the double gloving, other things, protective measures to be done. The main important is the discarding the semen sample. That one thing. But for the preparation, I think density gradient, usually before going for IUI, we'll prepare the semen sample before, and after the semen sample goes to us, you can send it for the CD councils. If there is any anything infections, if it is less or even if it is no, then the same preparation can be done for the real IUI. That we have done and we could for.
Okay. You treat HIV patients?
No, we actually send it because treating HIV patient is not only giving drugs, more psychological counseling is important. We actually refer to VHS now. They have a beautiful team and they do it.
Okay. So in an IUI, how do you select which method you give, Ramesh? This is for
density gradient method is actually very good, ma'am. Initially, we were getting a double-walled tube is available, but nowadays it's very difficult to get a double-walled tube because they say that no patients is willing for the same sample to go ahead with IUI rather than go for the donor semen sample. But I have done with a double-walled method, a double-walled tube, and we have done. We send it for CD count. We say there is no infection in the post to us. Then we repeat it for the one patient. We got positive, but unfortunately, the wife also HIV positive, and the baby ended up in, getting the infection. And it was like there is a one place near the Dindivanam, special care for these kind of babies. So in there, the baby is getting taken care of.
Ramesh, the last question. In a general IUI, when a patient comes to you, how do you decide it's just a sperm wash or a density gradient method? The last question.
I mean, definitely depends upon the parameters. Usually nowadays, the density gradient is giving a very good result. And also we have just found that the morphology is better when compared to the other methods. So we're just preferring density gradient for all the patients actually.
If the count is borderline also, what method would you prefer?
If count is very borderline, we can go ahead with pellet and smoke pump. Or even the pellet, you can take the pellet and give it for the mix with the 0.5 ml of sperm and give it for the example. If it is an XC, this is not easy, ma'am, because if you are putting a pellet, you can get a good number of hundreds from the work. If it is for the IUI, you can go ahead with the pellet and you can just go ahead with the IUI.
What is the minimum total motile count where you say yes? Because we know that anything more than 10 million or 5 to 10 is okay, but what is your take-home message? Even with the 1 million, have you done the IUI?
We have just did a small study to find out the total motile sperm count. We feel that less than 7 million is definitely not going to work for the IUI. If it is more than 7 million and more than better, it will go for the IUI. Otherwise, we counsel the patient for the ART procedure.
Yeah. I think just completed our yes.
No question to just Ramesh. I just wanted to know, is there any specific RPM that is recommended for density gradient? Some people do 1,500, 2,000 because we should not create iatrogenic ROS. Is that going to impact our technique of preparation and this thing? Anything that is
two things they follow, ma'am. If you're putting 3 ml of spermash media, better to go ahead with the 2000 RPM. Suppose we're having only 1 ml or up to 1.52 ml, you can go ahead with 1500 for the first spin. Second spin, you can go ahead with 1200 or even 1000 cm. If it is more than volume is more than 2 ml, up to 3 ml, you can put it. If it is there, 2000 for the first spin and the 1500 for the second spin.
Thank you.
There was one question they were asking, like where we have to do a PGT if there's Y deletion, something. I just didn't see that question properly.
Yeah, it's from the audience. So if PGT needed, if Y chromosome microdeletion is positive, I think is the question.
Yes, nowadays we have the option to do it. So if it is YCMD positive, then especially when we do the YCMD for a severe oligospermia, we get the positive result. on the Y chromosome, we have the option to do PGT and then transfer the embryos which don't have YCMD positive.
Thank you, Dr. Karthik. I think I really enjoyed, and I think I've learned a lot by the dialogue. And I'm sure the speakers also would have enjoyed. I'm sure the delegates would have had a good learning points, take-home points today. And yes, Dr. Vikas, I think we missed your videos. I think if you could do that.
Sure. So yeah, sure, ma'am. Thanks. So good evening, everyone. Myself, Vikas Singh. So at the outset, I would like to say sorry to everyone because at the start my network error was there and I was not able to introduce the chairperson and program went little off track. But I would like to share the corporate video of UNS at the beginning. Just give me a second.
The time is now. Time to rise above the disease burden. Time of changing lifestyles. Time to age gracefully. Now is the time for research-based scientific concepts of prevention and supplementation through proven nutraceuticals. Universal Nutri-Science for nutraceuticals.
At UNS, we believe in providing exceptional portfolio for patients and communities through unwavering supports of doctors and healthcare professionals like you. Over the year, we have built a very strong portfolio in women health and bone and joint. With our products like Primosa and CoQ in women health and Colaflex and Freeflex in bone and joint, we have been able to establish a leadership position. At UNS, we believe in the value of respect and entrepreneurship. We look forward for your support and guidance to establish UNS as a company which communities and industry will feel proud of.
UNS has the ability to build cutting-edge marketing strategies and has built itself up to be a credible partner of healthcare professionals.
When we decided to create Universal Nutri-Science, it was based on deep understanding of the market requirement, the understanding of science and the evidence. And together we created a portfolio of products which would benefit the patients and the prescribing doctors immensely. Today, Universal Nutri-Science is perhaps the only pure-play nutraceutical company in India. I have been in this industry for over 35 years, and I am bringing all that experience along with my colleagues to truly create a world-class nutraceutical company in India.
What sets UNS apart is its access to the finest R&D labs and state-of-the-art plants. We maintain standardized operating procedures, quality control systems, record-keeping practices, and hygiene protocols to ensure highest safety and quality standards. UNS is backed by one of India's leading dynamic and fast-growing private equity firms, Kedara Capital, combining global networks with local expertise. UNS is on its way to becoming India's #1 nutraceuticals company through the dedication and innovative spirit of its people. And a wholesome basket of world-class products. The time is now for you and us. Universal Nutri-Science.
So yeah, this was a short corporate video. Now I would like to just give me a second, share another screen. So, thanks note from my side. So, I would like to thank first of all Dr. Kundavi for giving the opportunity to Universal NutriScience to and collaborate with us. Further, I would like to thank Chairperson Dr. Ajanta Bhupati, Dr. Ramesh Raja, and Dr. Vasundhara Jagannathan. Your presence made this event more valuable. And lastly, our talk was very enriched, like Dr. Mona Panduranga and Dr. V. Geeta has given talk on coenzyme Q10, a molecule which has there in from decades in India, like from last 3 decades, and has shown the efficacy in management of male as well as female infertility. And they have deeply covered all the aspects of coenzyme Q10, from where it should be used, what dosage, in combination or not. Everything is beautifully covered by both the speakers. And lastly, followed by a wonderful discussion, hot topic nowadays, whether what gynec should do about male infertility. It was a very wonderful discussion between an ERT specialist and an andrologist, which is Dr. Kundavi and Dr. Karthikeyan. They have beautifully covered all the aspects which should be covered, and everything about the male infertility, starting from semen analysis to DNA fragmentation to genetic testing to ultrasound. All things have been covered beautifully. So thank you so much for the wonderful session. Now, lastly, I would like to thank every participant and contributor. Heartful round of applause to all of you. And thank you everyone associated with this program for your efforts and your time. So there is also Balaji and Manoj Joshi, which is the general manager of our.
No, we should not take more time, Vikas. I have already posted my message in the group, but it's a sincere gratitude and thanks to everyone. And it's a great opportunity for us. We wish to collaborate. We have been meeting all the eminent clinicians who have been helping us as a speaker chairperson. At the outset, we also thank participants. So thank you so much for your precious time taken out for this scientific event. Thank you so much.
Thank you. Thank you.
And big thanks from my side. And kindly excuse my video is not there. There is no current here. And a wonderful light you have given to my knowledge also, and by my colleagues' knowledge also. And thank you very much, madam. And thank you very much, chairpersons and speakers. We soon will meet. Thank you, madam.
Thank you.
Thank you to all the
Thank you.
audience.
Thank you, everyone.
Shall we leave?
Yes.
Thank you, ma'am. Thank you, everyone.
Thank you.
Thank you, sir. Thank you very much.
Thank you, everyone.
I request, no, RX team, can you stop recording?